Good afternoon, everyone, and thanks for joining our third presentation in our research education series. And for most of you, Mattie Tenzer does not need an introduction, but I thought I would give one anyway. Mattie is a graduate of the University of Virginia. She's been at Carilion Clinic in various roles for 24 years now. And what I want to say about Mattie is she has been instrumental in really getting the health analytics technology at Carilion Clinic here. She was instrumental in getting our REDCap, Trinetics, and Spark environments up and running. And she's also a key opinion leader among data analysts here in the Commonwealth of Virginia. So Mattie, I'm really looking forward to your presentation.
Thank you for that, Francis. Appreciate the invitation to present to you and to let you know about these different technologies that we have for you to leverage in research and QA/QI. So let's see if I can, your learning objectives today, I won't read through all of the things on the slide, but basically helping you understand how to navigate the process of research and QA/QI at Carilion, leveraging those tools and others, and especially using something called My Project Path. I've got the link to My Project Path on the upper left-hand side of almost every slide, so you don't have to worry about if you miss writing it down right now, but I highly encourage you to look at My Project Path and use that as a resource going forward. We're constantly updating it. We're about to do an overhaul. New processes and new technologies that we have will be launched in there for you to learn about as well. So the HART services, that's the Health Analytics Research Team, of which I'm the director. We basically handle all the proper access, acquisition, storage, and utilization of all research and QA/QI data, including PHI. And these are some of the aspects that we'll be going over today listed here, but we'll step through each of them individually. So just a little bit about the team. We actually have 20 team members. That includes myself, which we provide end-to-end support, quite a bit bigger than 24 years ago when we weren't even really doing research at Carilion. We do have a mix of grant-funded and institutional supported projects. So you don't have to have funding, but if you do have funding, we do leverage that to help support our team members and grow the team to support all the research going on. Among the 20 team members, we actually have over 250 combined years in healthcare research and 165 combined years at Carilion, of which you just learned I'm 24 of those 165. But we have everywhere from new people with new skill sets coming in to also very seasoned people who have a ton of experience of how to do research and QA/QI projects here at Carilion to help you. We have a good amount of diversity on the team, probably one of the more diverse teams at Carilion, heavily female. We've got veterans, we have non-whites. We promote diversity. We believe that diversity of all types helps us provide better service to all of our clients and brings different perspectives to our projects. We do offer full support in research informatics, which we'll go through, biostatistics, data science. We actually have a data science division within those team members. Epidemiology, research design, data extracts, and research navigation services to make sure that your project is successful from start to finish. And we are a major component of the NIH CTSA iThrive iBirdie group, which is the integrated biostatistics, epidemiology, research design, and informatics section that is being launched out of the CTSA that we have with UVA, Virginia Tech, and ANOVA. And we also support the innovation department for projects that you may be involved with them, including app development with them as well. This is what we're going to go over today. This is just of a PDF that you can get to. It's got some links in it if you just wanted some quick links to different aspects. But this is basically what My Project Path covers, is all the way from idea to publication, all the resources in between that you might need. And that's what we'll be stepping through. So again, the link is in that upper left-hand side, and you'll see shortly an overhauled version of this, which is easier to navigate. There's that interactive PDF option that you have right here that you could click on and get to that PDF and get the basically short little links, but nothing that has any tracking or more information. We're going to look into the full version as sort of the structure that we'll have as our discussion today, which gives you a very comprehensive view of all of the different services that my team offers and assists with. So if you pick the My Project Full, you actually have an opportunity to put in your email address. You can put in a title for your project, especially if you might want to be doing multiple projects. That way you can keep track of each of them individually. And you can save and return later. And if you do that, it basically says your survey responses are saved, but basically it will send you an email link so that you can go back, because clearly you're not going to sit there and do your research project all in one sitting. You have to, put it together and talk to people, submit to R&D, go to the IRB, go do your project, write up a manuscript, present. You can't do that in one day. So you can save this and therefore track your project all the way through and get the resources when you need to. So the first thing is we try not to assume any level of knowledge of somebody who might be using this tool. So one of the first questions is, is your project research or QA/QI? Even for people who are highly knowledgeable, this is sometimes a very tricky question. It's not really black and white, but it's sort of a continuum. But basically this is IRB guidance right here. This is straight off of their website about how do you make a determination between research and QA/QI. And certainly if you have any questions about that, the IRB is fantastic at providing insight and advice into how your project may qualify. And you can actually submit for determination, in fact. After that, you have an opportunity to sort of organize your thoughts. The advantage of putting your thoughts in here for a project is in the end, this will actually generate a file for you, a PDF, and you can copy paste that into your R&D application. We are going to be looking at actually integrating my project path with the R&D application process, which is both of these things are in REDCap. So there's an opportunity there for you to be filling things out in project path and have those things push into the R&D application. So once we overhaul the application for my project path to make it a little bit more accessible, then we're going to look to see how we can integrate it with the other tools that are out there. First, the R&D application, and then secondarily, we're going to try to integrate it with Prism, the IRB application as well. So if you do put information in here, it can help you, sort of put together your understanding, track what your background you've done, and start to think about, the time period of your data, something prospective or retrospective, things like that. There's even an area here that we're not going to dig into at all, but just to let you know that if you're using this and you really haven't had a lot of background in literature searches, there's a, sort of an idea here of how you can go about your literature search. I would draw out that there's this PowerPoint presentation down here about literature reviews that one of my team members put together. We're actually going to be turning this into a little embedded video. That's one of the goals for this fiscal year, is to take these PowerPoint presentations and turn them into nice little short videos that you can watch just a couple minutes at a time at your leisure to learn about different aspects. And I actually really like this literature review table template that one of my team members created. And it's a really nice way to sort of take a look at all the literature results, put them together in a way that you're summarizing them so that you can use them for your background section in your protocol. And if you do it properly, you don't have the risk of any type of basically you come up with your own language as you go. It's a plagiarism. That's the word I was trying to look for. You can help avoid that. So in the library services, we gave the email here. They provide great service for helping with your literature review and background searches too. So another question we like to ask early on is whether or not you have external collaborators so that you can start to keep in mind all the different aspects if you do have somebody external involved. There is a difference between having the VTC SOM, that's the School of Medicine with Virginia Tech Carilion involved, versus other non-VTC SOM, non-Carilion people. The VTC SOM is currently considered to be an extension of our workforce. So there are rules that apply to them, but there are even more agreements that need to be put in place for non-School of Medicine. So either way, though, we do need to get information for our external collaborators. If they're going to have access to Carilion systems or Carillion's data, they need to sign an access confidentiality agreement. This is something that every Carilion employee does every single year during our in-services. Obviously, non-Carilion people don't go through the in-services, so therefore we get them to sign an access confidentiality agreement annually also. It's just not done at the same time that ours are done. And then there's additional information that is gathered on them, like their driver's license and birth date and things like that, all of which is already gathered on Carilion people too. So I wanted to just point out that it's not a different requirement for external collaborators. It's just collected at a different moment since they're not employees. And so there's some information here, and also that there needs to be a contractor agreement that is handled by the Research and Development Office department, and they can help with all of that, all of the agreements there. We also like to ask whether or not there may be funding so that you're aware of some of the resources that are available to you for funding. and also things that you might need to consider in regards to funding. Here is where also you can find a link to the portal of the iThrive, that CTSA that I mentioned. And there are some internal and external funding opportunities. Carilion puts its funding opportunities in there, but there are also iThrive opportunities and other opportunities as well. So it's a nice place to go and search for whether or not there might be some funding that would apply to your project. It also has other resources that you might want to explore, and we'll talk a little bit more about that later. And one thing that they just want us to remind you is if you do use any iThrive support, you want to make sure that you acknowledge that support in any of your presentations and manuscripts. So we have conveniently enough included that in my project path, so that you can find that at the appropriate moment, copy paste that into your presentations and manuscripts. My project path also does have the opportunity to provide you with some general cost estimates as you compile your project in case you are trying to get funding and would like to know approximately how much you would need to consider to include in that. All of these things, if you click no, it just means you don't answer all of these questions. It's just, additional information if you want it. It also reminds you that if you do have external funding, you will need to do a conflict of interest disclosure, and a COI will also need to be done by your external people as well. So then we're talking about how to explore your patient cohorts or your data. This is where my team becomes heavily involved with you to try to support you. So one of the questions is, do you even involve Carilion patients? And if you would like to explore those cohorts better and try to figure out, how would you define those groups, what ages, what outcomes, how would you define diagnoses, procedures, timeframes, if you have enough patients. And if you're interested in that, we have a tool called Trinetics, and it is a international vendor that we'll go through in a couple of minutes, about not very long. We have full training on that. This is a PowerPoint presentation. I'm going to grab a couple slides and show them to you, but there's a full PowerPoint here. Again, we're going to work that into a video snippet in the upcoming months for you to review. And then there's also this Trinetics user agreement that you can pull off here. If you're working with other external people like Virginia Tech, they can also sign this agreement. You can sponsor them basically to work in Trinetics on a project with you, so that the Virginia Tech people can have access as well to this and explore the cohort with you to define your populations. And then if you would like to see the language to use in your IRB application, if you do use Trinetics, we're going to provide that information to you as well. And basically Trinetics has 120 more plus healthcare organizations. It is basically created mostly to bring in clinical trials from pharmaceutical companies, of which they've got 13 out of the top 50 pharmaceutical companies. And overall, they've got over 250 million patients. Specifically for Carilion's data, we've loaded it since 2008, which is when Epic came up at Carilion. And basically, you can explore it in a de-identified manner. But if you get a patient cohort together that you either want to reach out in order to enroll potentially in a prospective trial, or if you want to re-identify it in order to get more data on it for a retrospective project, my team can actually do that re-identification once you have the appropriate permissions. So it's a free business model for us. Actually, the tool is we've got over 420 users here at Carilion, and that also includes our colleagues at Virginia Tech. It's part of a CTSA initiative, and it does, as I say, bring in sponsored clinical trials. We have actually had publications that have been done completely inside the tool. It's got some fairly robust analytics, and they're expanding out every day. So you can actually create an entire paper directly out of the data in Trinetics, depending on your data points that you need in your questions. So what we fed in are all inpatient, emergency, outpatients, basically every type of encounter that we have at Carilion. It includes demographics and that encounter data, the diagnosis and the procedures related to those encounters. If you think about it in terms of claims billing data, those are the types of diagnosis and procedures. We also have laboratory values in there, any that have a numeric result. Anything that was positive or negative, we actually map over to a positive as a 1 and a negative as a 0. We actually did this pre-pandemic because we were looking at things like hepatitis C. We're looking at drug screening results. Turned out to be very helpful because when we got to the COVID screening, those results were positive and negative. So this allowed us to bring those results in as well. And they actually TriNetX took the method that we did in terms of the mapping, and they applied that across all of their clients in order to have a COVID registry across about 80 something healthcare organizations are participating. We also bring in medications and vitals. The medications are all prescribed medications in addition to the administered medications, especially in the inpatient area. Vitals is sort of a subsection of vitals, and we've got like heart rate, blood pressure, weight and height, things like that. And then we've been looking to supplement those. We do bring the oncology data in from the cancer registry. So those, what is reported to the state is scraped and sent into TriNetX. And we have this year also integrated with claims data, which is interesting because it allows you to see a better look of what the patient population is doing, even if the care is provided outside of the walls of Carilion. Now, for those, we obviously can't re-identify it because that would be re-identifying claims that don't belong to Carilion, but it does give you an example of, or a better look at what a population looks like. So, for example, I need to get my flu shot, which actually I've already had, but I had mine at Walgreens. I'll share that with you. So if you looked at the Carilion data alone, it wouldn't appear that I had my flu shot, even though I was falling into the denominator as somebody who should have a flu shot. If we look at the claims data with the enhanced Carilion data, I would also show up in the numerator because I got mine at Walgreens. You couldn't drill into me. You couldn't find out that I had my flu shot at Walgreens, but at least the count would be correct and you can see more of that information. This is good for outcomes as well. If you had a surgery someplace and you wanted to see whether or not there were, say, post-surgical site infections, and for some reason they weren't presenting back to Carilion, you would have a fuller picture of those by looking at the integrated claims data. We also have the integrated mortality data that TriNetX sources as well. And this is important because we aren't always aware whether or not our patients have died. Maybe we've just lost them to contact, but they may have also deceased. I know, based on date of death, there are patients in Epic that would be 125 years older right now because there's no date of death. So presumably they've deceased, we're just not aware of it. So through TriNetX, we're supplementing with that mortality data so you get a more realistic view of that. And if anybody ever wants to go into how all of that is done in a de-identified manner, I can talk your ear off about it, but we don't have time today. We also this year have done integrated with natural language processing. And this is where TriNetX is running a process through all of our notes from Epic and gleaning additional facts that fit into the tables above. So they are grabbing, say, additional medications, maybe over-the-counter medications. For the first time, we can really see how many patients are taking aspirin, that as documented in notes. We're also picking up additional vitals. We've had problems in the past pulling in, say, BMI, and now BMI is being picked up because it's mentioned in the notes through natural language processing. So that has been very interesting. We are now loaded from 2019 through current, through about August or September at this point of 2022. And we are working on the backload of 2015 through 2018 at this time of the natural language processing piece. So if you use TriNetX, there are different ways that you might incorporate that into your protocol. So you might work with us after you've been trained, and we can do a brainstorming session with you to figure out how many patients at Carilion meet the inclusion-exclusion criteria of your particular project. And so right up here, we've given you a little piece of information that you can kind of copy paste into the protocol. You can change this, of course, but this is sort of recommended language. And if you're going to re-identify those patients, we've given you another text blurb that you can copy paste in, revise as you need to, reminding you that if you do use TriNetX, especially if you do a full publication out of it, you'll want to cite TriNetX, and there's some example language that TriNetX has provided to us for that. And these are language, all of these snippets that were for your IRB protocol, we've worked on with the IRB to be language that they find helpful in their review. So we also wanted to point out that now that you're sort of thinking about your patient population and your study design, we have a great team of research data engineers and biostatisticians who can work through all of your data points, whether the data is coming from TriNetX, whether it's coming from Epic, whether it may be even coming from some other external source. We work with those as well. We'll talk a little bit about that later. If you work with somebody on my team, you do not need to include us on your IRB protocol. It's part of our job responsibilities, so we don't have to be included. Of course, it is appropriate to include us if we have, major design impact, et cetera. I think that's one of those things you just kind of know whether or not we need to be included for the design aspect, but we're not required to be included because we'll be exposed to your PHI. If that's part of your project. Like, for example, our biostatisticians don't need to be on your protocol. You don't have to de-identify the data for us to work with it because it's part of our job. If you think about it, if we did anything wrong, we would be fired for doing that breach. So that's why we don't have to be on the protocol. But if you do put us on the protocol, we have all done our city training, so it shouldn't slow down your project either. We also have access to all of the share. We can get access to all the shared drives for the project. We have access to all the Spark folders, which I'll go over in a little bit, in order to facilitate the analysis of your data sets as well. And I've given our link to our website there, which we are also working on revamping, but you can get some good information about the type of services as well there. So this is sort of like an other services area. So just letting you know that these are not areas that my team supports, but in order to provide that end-to-end support, we wanted you to be aware that there are a lot of other, research support departments around Carilion. There's the human factors approach. If you click on that, you basically get a link to their webpage. If you have any potential intellectual property, new ideas or patents, if you click that, you can get the email address for the innovation department. If you need help at the basic science research lab, and I think I may need to update this. Oh no, you can go to the research lab here. And find out about specimen storage and collection and those resources over there as well. So the next embedded PowerPoint presentation, and again, we're just going to go through a couple of slides. It's nowhere near this entire data management overview here, which you can access through my project path, and that we will also be turning into a video. But it's important to think about what your data sources are going to be. And EPIC is obviously our most frequent data source, given the fact that it's our electronic medical record. So usually the type of data that people want pulled out of there, demographics, encounters, diagnosis, procedures, labs, but it's also flow sheets, sometimes nursing assessments, smart data elements. There's an awful lot of data in EPIC that all over the place. It actually comes to tens of thousands of tables. And that is why my entire team is certified to work with the EPIC EMR data. It is incredibly complex. We also have other data sources as well. For example, infection control susceptibilities. That is the antibiotic susceptibility of different bugs, and not all of which are actually fed into EPIC. So there's a separate source for that my team has access to. We also support projects that have to do with the trauma registry. We obviously support Trinetics data sets because we can do a data set download from there and work with it. And we've done things like all payers claim databases and other national data sets as well. So just a very quick thing, I'm sure everybody here knows the difference between retrospective and prospective studies, but I just wanted to make sure that we're very clear that with retrospective studies, one confusion we often have is that all the data for retrospective has to be in existence at the time of the submission to the IRB. So you can't say, well, I want all the patients who had a certain procedure this year, and I'm going to submit, I want it to be retrospective, but I want to follow them over the next year. Because you're following their outcomes over the next year, that's not retrospective anymore, that's prospective, and it may require consent. Retrospective studies may also require consent if it's feasible to consent the population. So those are all things that need to be considered. And retrospective studies are typically data that is coming from the EMR that's been collected for other purposes. Maybe it's clinical, maybe it's a quality, collection that is being kind of reused for another research purpose at this point. And because I'm not sure that you have actually a meeting with privacy and IT, they asked me to bring these things up. Protected health information belongs to our patients. We need to make sure that we are always thinking about the security. My team has several solutions to make sure that the PHI is protected. And there's multiple PHI elements. There are links that you can go to find out about them. I think everybody kind of commonly recognizes that a patient name is PHI. People don't always think about the medical record number, the master patient index, the account numbers, the encounter numbers, which is the CSN, that's actually PHI. It's obviously harder to take a look at a number and know who that patient is, but it is considered to be PHI. Not just date of birth, but all dates are PHI. So that's every procedure, every admission, every encounter date, any time of medications given. All those dates are actually considered PHI. Social security number, we really don't allow that. There has to be, we've been told from compliance that there really has to be almost like a legal reason to have that. And then the IRB can work with you though on exceptions if needed for that. Obviously email, addresses, phone numbers, any zip code that's more than the first 3 digits is all on PHI as well. So the most important thing is only collect what you need. And the second most important thing is we will set up a secured share drive for you if needed. And we also have a Spark, which we'll talk about in a little bit, to basically keep the data secure and only give access to the people who should have access to it, that are on the protocol and approved by the agreements in place. The other thing is that when you need to do chart review in Epic, that you need to acquire chart review in Epic for research projects. You need to acquire and use an Epic Research Access context while you're doing that chart review. And the reason is because if you're looking at a chart that you don't have a relationship as a clinician, then using that research access is what explains why were you in that patient's chart. If the patient said, well, can you tell me everybody who's looked at my chart? So it kind of separates out the clinical use of Epic from the research use of Epic where you may not have a relationship with that patient. Interestingly, if it's a QA/QI project, that falls underneath data that you're exposed to as part of your job. And so you would use your regular clinical context to do QA/QI. You don't need an Epic Research Access for that. We do here use REDCap, which I will go into, which is required if you're collecting PHI that's manually collected, if you're doing chart review, potentially and gleaning through, history and physicals or something. REDCap here at Carilion is very secure, which I'll go through. It's protected and logged. Just one other thing is just make sure that if you are working with external people, make sure that they use their institution's email, that you use your institution's email, don't use Gmail or your Cox mail or something like that. You really need to use the institution's email. PHI is protected internally with Carilion's email. It's not protected when it goes outside of Carilion. And definitely work with the IRB before working with anything that's identifiable, because you may have to get consent for it. So, check with them first and before you launch on any type of reviews. So we're going to go into a little bit about data management. What questions are you trying to answer? Most importantly, what data are available? Have they been consistently collected, and how confident are you about that accuracy? We've had a number of projects that sound fantastic. And then as we start going into pulling the data for the clients, we realized that there wasn't really any consistency on that retrospective project and how the clinicians were collecting data. Because of course, they were collecting data to treat the patient. They weren't thinking about a research project that would be done 3 years in the future. So there can be some inconsistencies there. And if there are, then how are you going to address those documentation issues? And exactly how are you going to make those definitions? And talking about like ICD codes, there was a major change in October of 2015 where we went from ICD-9 to ICD-10. So if you're planning on going back in a retrospective study further back than 2015, which is feeling further and further back now at this point. But you need to realize that the coding is very different. And so we have to kind of separately define those populations, and there may need to be additional chart review in older data sets than in the more current data sets, because the granularity is not there with the diagnosis codes for ICD. Also need to think about other confounding factors. What other things are going on during the time that your project is going to span, especially if it is retrospective. Were there changes to the EMR? For example, for a long time, we couldn't get to ejection fraction because we didn't have the cardiology project from Epic. And then we got Cardiant, the cardiology project, and now ejection fraction became available. So were there changes throughout the time period? So if you looked at the pre-Cardiant, you would say, oh, well, not very many people were having ejection fractions and done, or maybe there aren't that many that were under a certain value. Well, the truth is there just weren't that many because they weren't documented because we didn't have Cardiant. So you have to consider all of those changes with the EMR. Also, other initiatives. There were times in the last 24 years where it seems like everybody's working on the same sort of initiative. Everybody was working on mortality. And I know that's like a big, push right now. So how are you going to measure your outcome for what you want to do, say for mortality? And how do you separate that out from the outcomes of other people's projects who are also trying to tackle the issue of mortality? So you have to think about, the bigger picture of other initiatives that may be impacting your particular project and the outcomes that you're trying to measure. And then defining the population without bias, considering attrition. What happens if patients stop coming to us, they move out of the area, they choose to go get their care at a non-Carilion site. You can't just assume, well, just because we haven't seen them doesn't mean that they didn't develop some condition that was our outcome. It may be that we're simply not seeing them anymore. And so there are ways to design those projects to manage all of that. And as I said, we have a great team of biostatisticians who can help you with your study design to make sure that bias can be addressed to the extent possible. Okay. So very briefly, I know this is a very small slide, but I just wanted to show you that we are a fairly integrated system with Epic. We have almost everything they have. There are kind of two things we really don't have. We don't have Tapestry. That's an insurance payer piece. There are probably a couple other ones that they've come up with since. We also don't have Beaker. That's probably the more relevant one. We don't have the lab system. So we are integrated with Quest, which is our lab system. The data does come into Epic, but it does cause some interesting data concerns. For example, we don't have something called the LOINC code, which is a national code for all the labs out there. So if you're looking up and I was saying, oh, well, you wanted these labs, which labs do you want? And you said, here, Mattie, here's a list of LOINC codes. I'm going to have to do a crosswalk anyway because we don't have LOINC and Epic since we don't have Beaker. We also, another interesting thing is that we didn't come up with all of Epic all at the same time. Different places came up at different times. So we started off with the ambulatory area in the Roanoke area in February of 2008. So the PCP offices came up first, and then Roanoke Memorial Hospital came up August 26th of 2008. And that was then later followed by New River Valley. I'm not going to go through the whole slide, but my point is that each facility came up at a different time. And in addition, we had different modules that came up at different times. For example, Cardiant, my example about ejection fractions, didn't come up until May of 2013. So how complete your data your data set's going to be prior to these dates is may be an issue depending of how you define your project. So you need to be aware of whether or not there may be incomplete data prior to any of these live dates. And actually, you may have to do paper chart review if you're going to go further back from that, and it may not even be available. So now we're sort of thinking, okay, we've got the data part. Where are we going to keep that, put that data? How are we going to analyze it? So we first of all want to make sure that we put it in a very secure place. If you have external collaborators going in through our share drive is very difficult for them. We don't have very good analytic tools. If they go in through, say, VTC apps or Carilion apps at CarilionClinic.org, there really aren't good analytic tools. So about 2 years ago, we launched something called SPARC, which is Storage and Programs Accelerating Research Collaborations. And that is a place for secure storage of data and the tools to leverage with it. So there is a full-blown presentation right here. Again, we're going to put a series of videos embedded in this, and you can indicate if that's what you're going to use. And then I'm just grabbing a couple of slides from that part of the presentation. So we will probably create a secured share drive for you. This is good for your general documentation around your project, preferably not so much PHI because the share drive is not as locked down as our secure research environment. So the SPARC is becoming the preferred mechanism for data sharing, especially if you have external collaborators. It is cloud-based. So this is accessible literally anywhere that there is an internet connection. So that is very friendly to external collaborators. We have really great tools in there, including SAS, which is considered to be the gold standard of analysis, both via and statistics. We also have, for those more interested in data science, Jupyter Notebooks and R, both of which are integrated with SAS and also standalone in the environment. We have our Studio, which is great for our medical school students who are trained up in Studio. Also Python, again, more with data science. And then we actually, this year, we launched NVivo. And NVivo is a qualitative analytics software to complement SAS, which is the quantitative analytics software. So we really have a very full offering of top-notch, best-in-class solutions here to help meet our collaborators and our internal needs. Another thing this year is that we got approved within Spark for all data, de-identified data, limited data, and now identified data. Fully identified sensitive data can be stored in Spark, which is amazing. We passed with flying colors an audit through IBM, the system and the security around it. So you'll want to make sure that you specify in your IRB protocol exactly what data you're going to be storing in there. And I will show you in a minute that we have language that you can use. We're also going to be using this platform to integrate with the iThrive, that's that CTSA data commons for ease of launch as well. So that's to come this year. This is just a quick look at what the environment looks like. You kind of land on an environment, looks a lot probably like your desktop. That's, it's common look and feel. We have 3 different spaces. There's one that you would not see, which is the development space for my team, where we kind of do the pre-work in the staging area before we move a data source out to you, or before we may move analysis out to you. Then there's the source data. So there will be a folder for your project underneath the source data. And my team has write access to that. So that's where we put the data set. You've got read access to it. And that way you can then make a copy of that over to your shared team data. That's your workspace where you've got full write access. It's your space to collaborate. You can do what you want over there. But if you mess anything up with that data set, all you have to do is go back to that source data and you can pull that source again and know that it's there. It's backed up. It's not going anywhere. You can't lose it. Unlike, by the way, the shared drive, we have had multiple problems where people have, by mistake, deleted files from the shared drive, deleted an entire shared drive. They deleted their entire project folder. And sometimes those are not recoverable. So far, my team has had backups of everything, so we've been able to help. But shared drives can be removed, corrupted, and deleted by anybody who has access to it. This environment, which is AWS, has a backup system so that it is much more recoverable. So here back in my project path, you would indicate what you're going to end up using here. And if you're going to use Spark, just to be helpful, we've given you, again, a nice little blurb that you can copy paste into your IRB protocol that the IRB has approved with us. And so this helps mitigate the risk of using PHI quite a bit. So now this is a REDCap start. We'll go into this a little bit more so you don't have to try to read what's on the screen here. Again, there's a PowerPoint presentation. It will become a video. And basically, you're going to want to use REDCap if you're collecting PHI, or we also use it for surveys. And so we have language here too that you can copy paste into your IRB protocol again. We don't want anybody to have to keep reinventing this wheel. And also at the bottom, REDCap is actually a Vanderbilt system. We'll look at that in a moment. And it's through a CTSA. So they also like acknowledgement if you're going to use them in a manuscript or presentation. And this is a very long acknowledgement down here. If you have to, you can just use the first sentence. So REDCap, it stands for Research Electronic Data Capture. We can also use it for QA/QI and grants. It is secure. It's web-based also. So again, incredibly accessible anywhere you might be. Originated out of Vanderbilt University in 2004, and it is used widely to over 2,000 institutions, 100 different countries. It has a really strong community working together to improve it. We are actually on the latest and greatest REDCap version. We work really hard to get us to that point, and we're bringing up new functionality every week. It is HIPAA compliant. with, we have a stringent change control process around it. There is a very robust logging. We can tell who is logged in, what did they look at, what did they view, what did they change. Everything is tracked very much like Epic, actually. And actually, I took off the slide, which I call the geek slide, which shows the setup of REDCap sitting behind our firewall. It is protected by our technology services group at the same level of Epic. And we also back it up every 4 hours. That's a little less than Epic, but thankfully we don't have downtimes. We've had maybe 3 since we brought it up 5 years ago, and we didn't lose any data in any of them. Because we have such stringent change control around it. We also are CFR Part 11 compliant ready, which means that if you have a federally funded project, we can help support that. We launched eConsents during the pandemic because to support the fact that now enrollment was happening a lot remotely, and that went very well. So that is part of our standard process that we developed with the IRB. It has data collection tools that we can create. And as I said, we can do surveys. Those surveys can be distributed through email. We now do text surveys as well. That's something else we launched in the pandemic. We can provide a website URL or a QR code. And then coming soon, we're actually currently working on an Epic REDCap integration project, which will help bring data from Epic into REDCap without actually needing chart review to some extent. So that's exciting development there. It'll be launchable from Epic to push a single patient's data into REDCap once they enroll. Alternatively, from REDCap, a set of patients can be imported in based on criteria to set up a project. So that will be coming this fiscal year that we're in right now. So the project types we can do surveys, as I mentioned. We can do traditional projects with data entry forms. They can be longitudinal, collecting data on the same subject over time, and it can be any kind of combination thereof. So you can see that there's a ton of different types of fields that we can put rules around. This helps not having typographical errors, enforces quality data collection better than Excel. Can't be corrupted like Excel can be. I know we've had clients before have missorted their Excel document and they can't tell which column they sorted it on, so they can't really get it back. REDCap, and basically you can't do that to REDCap, and it's backed up, so it's all very much recoverable. You can also use branching logic, which is exactly what my project path does, so that as you answer certain questions, other questions either pop up or go away as appropriate. And we can build matrices, and actually the matrices are even more advanced than this. We have recent functionality that came out that they're even better looking, and you can have like heat map bars going across. Very exciting. So all kinds of new tools in there as well. And we also, I didn't include it on this. We can also, you can see that the data security is very granular. We can also do multi-language, and we've done one multi-language project already, but we're currently working on about 3 others. But you can see here that the granularity of security is very precise. So different people can have access to different things. Your external people who don't necessarily need access to certain pieces can have it. Maybe you're collecting data in a specimen here. That specimen's going to Virginia Tech. They're getting a number 1, 2, 3, 4, 5. They need to put in some results on that specimen. They can see the 1, 2, 3, 4, 5. They can't see that those specimens belong to which patient. So basically a quick checklist of your data management. You want to explore your cohort through Trinetics if you're going to be looking at patients. Make sure you can define your population, determine the data points and the data source, determine if it's going to be a data extract that my team might do from you from Epic or some other source, or whether or not you might need to do chart review, or it could be both, or you could have a survey. Also, you want to determine who's going to have access, what type of access do they need, if they need agreements in place, and don't forget about the biostatistician. If you do have an external biostatistician, you will likely need to add them to the protocol as well, so don't forget about that. And then you'll write up your protocol to include Epic Research access if it's a research project needing chart review, REDCap, the secured share drive, and Spark, using the language that we gave you, all for that. My team can help you with all of this all the way through. That's what we are there for. So just a little bit of an extra thing, I mentioned cost before. You can actually get sort of a cost estimate in my project path if you're looking for it. And to do that, you kind of have to do, it's like t-shirt size, a small, medium, large, extra large, or this is a survey. By answering some of these questions, then basically we can come up with sort of an estimate of how much something is going to cost to do. And you can also add in some additional costs in this, particular example, gift cards for participants. And then it's giving a breakdown of it. So it's sort of saying red cap storage fees. Yes, there will be one. Here's an internal cost for that. Medium data extract. Here's a general cost, survey setup, etc. And so it kind of gives you a bit of a breakdown of costs if you want to submit that in. And then does your department chair require submission to R&D or approval for QA/QI projects? And this was an example of a QA/QI project. Obviously, if it's research, you need to go through R&D. And so we've given you not only the email address for research and development in case you have questions, also the link to their application right here. And then this box here, the summary of the information, is actually piped in from the information that you entered earlier. And so you can copy paste that in. And this is the piece that we want to start bringing some of these pieces across and tying them into the R&D application. And so these next two things are just whether or not you've submitted and received approval. That's for your own tracking purposes, if you want to use this as an actual tracker of your project. And then your next step would be the IRB. So this is a convenient place to get to the IRB link. And actually, as we're revamping this application so it's easier to navigate, you'll be able to get to this link even faster. It'll be like, oh, I'm in my project path. Click here for IRB. Oh, there's my link. Click on the link. So you don't have to go through all of these steps just to find the link to the IRB or to R&D, and just a tracking mechanism there. And this is very, very small kind of stuff, but basically once you get to the level of analyzing and presenting, and again, the revamped one is kind of breaking this into different sections, but it's giving you the language again for acknowledgements. It's also giving you a link to poster and presentation templates. Those exist within Inside Carillion, so you do need to have access to Inside Carillion to get to those, but this is just providing some end language at the end. And then finally, it gives you, okay, great, thank you, you're done. You can actually download your response. You can also send yourself another link so you can get back here as well. So you can save all of that. Good for copy pasting into your IRB protocol. And basically, if you get it sent to you, this is what it ends up looking like. It basically summarizes everything that you've done. So post data management, after you get your R&D approval, which obviously you then submit into the IRB, and then you get your IRB approval, after that, our research navigation services will contact you. So we get notified that your protocol has been approved, and we will reach out to you and say, basically in reviewing your protocol, it appears here are the services that you need, and we'll list them out in the email, what we found on your protocol that you needed, and we ask that you confirm that because something may have changed, or we may have missed something in it. Maybe you missed checking a box and we didn't see that you had talked about it down further. So, respond back to that. And then we basically submit all of what's called the Edison tickets for my team to be working on all of this. And here's some contact information. Anytime you have questions, you can reach out to my team, HART@CarillionClinic.org. I'm on that email along with 5 or 6 other people, so we can get back to you with any of your questions, set up consults with you. We do have office hours, virtual office hours, and I can send that link out later. A lot of us put it at the bottom of our emails. We also, if they're posted on our website there as well. And then again, that is the link to my project path if you want to get there. I'll also make sure the office hour link is put back into my project path while we're going through the revamp of it. And I think that is the end of my presentation. If there are any questions that have come up.
No questions have come through in the chat yet. However, I welcome folks to either put any questions in the chat or feel free to unmute and go ahead and ask your question. It was a lot of information, so people might still be processing.
It is a lot, and if I realized I was going to end 10 minutes early, I could have gone a little slower, but I actually cut a few slides out since there was so much.
No, it was great information.
So if you're interested, say in Trinetics and you want to explore that tool, just reach out to HART@CarillionClinic.org. We can send you the agreement and let you know who needs to sort of sign off on it. You basically just have to have your department chair or head sign off that they want you to be doing that. It's just for our documentation that somebody says your time can be spent on that. If you have somebody who is external to the company and you want to sponsor them, like at Virginia Tech, then you can work with Frances Farrell. Dr. Farrell signs off on those external ones. We do require that our external collaborators be working with an internal investigator as their sponsor, since this is Carillion's patient data. So it doesn't have to be a live project, obviously, because this is often done in preparation for a project. So it just needs to be a collaboration that is occurring. And we have separate training for that. We offer brainstorming sessions. As I said, there's a lot of analytics you can do, Kaplan-Meier survival curves in there. They are now launching logistic regression. There's some data science data modeling that you can do in there that my team is on part of the beta site on for that. So that's if you're interested in any of that, please reach out. It's really cool because you get to use clinical terms. I shouldn't be launching into this, but you can basically use clinical terms as a clinician to query the data. You don't have to know codes. Now, if you happen to know the codes, the diagnosis codes or whatever for it, you can actually use those, but you can actually use clinical terms and you can put timeframes around it, and you can have criteria interactions. So somebody has medicine prior to an admission and then whether or not they had outcomes afterwards. You can do all that with timing as well. So no questions?
No questions yet, but like Mattie has said, feel free to reach out to her or the HART team, I think, after this presentation, especially because I'm sure people have lots of ideas, but maybe don't have them well formulated yet. So they might not be ready to ask, but there are questions, but lots of wonderful resources. Thank you so much for sharing, Mattie. I always learn something new when you give this presentation. So
my pleasure.
Just a quick reminder to folks that we do have an evaluation link in the chat. So feel free to complete that. And then, encourage your colleagues and your residents to join us for our future sessions within the research series. And I think that's it for today, unless there's any other questions.
Just lots of thank yous.
Fantastic. All right. Thank you all for coming. We really appreciate it. And thank you to Mattie for a wonderful presentation. Have a wonderful rest of your day. Bye all.